So achalasia is quite a rare condition. Its incidence in the population is about 1 in 100,000. So that means 1 in 100,000 people will get this disease. And the problem with achalasia is that patients are unable to eat or drink. They have difficulty in swallowing. The reason for that is because the muscle, which is at the junction between the food pipe, which is the esophagus, and the stomach, is very tight and it fails to relax. So what happens normally is when you swallow, you get the food going down the food pipe, which is the esophagus, and then that muscle normally relaxes. So the food can go easily into the stomach. But with achalasia, that muscle is tense, it's under higher pressure, and it doesn't relax. And therefore, there is a holdup of food and fluids, and patients can often get pain in their chest, or they can have difficulty swallowing or difficulty drinking. They can also get regurgitation and vomiting. And as a consequences of these different symptoms, they often lose weight because they're not able to take enough calories on board. So the symptoms of achalasia often can be quite subtle. And interestingly, if you look at the literature, many patients remain misdiagnosed for several years because it's sometimes not very clear as to what the diagnosis is. You may just have a little bit of regurgitation and a bit of water brash and difficult taste in your mouth. Or indeed, you may have difficulty swallowing foods and difficulty swallowing liquids. But it's a gradual process. It can sometimes take many months or years, and therefore it is often difficult to diagnose. One of the other aspects is that it can also cause chest pain, and the chest pains can be rather atypical. So it's not unusual for many patients to be investigated for heart problems, and then that is all normal, and then they end up actually having investigations to diagnose their achalasia. So I think in terms of the cause of achalasia, we're slightly uncertain, and we don't really have a definite cause that is a trigger of achalasia. It can run in families. It's quite a rare condition. It's 1 in 100,000 people. It is thought to be triggered potentially by an autoimmune condition, but we don't really know as to what the exact cause is and why the muscle at the lower end of the esophagus fails to relax and why there is difficulty swallowing. What we do know is that we can treat it. So and it's important to get patients' symptoms better so they can eat and drink. And therefore, there's a lot of research that's going on about identifying the exact cause, but at least we know that the treatment is by releasing the muscle at the bottom of the esophagus, and therefore we can help patients with their diet and with eating and drinking. So there are many treatments for achalasia, and one of the treatments that I specialize in is doing more minimally invasive and natural orifice surgery to treat achalasia. You'll recall that I said earlier in this video that actually the achalasia is because the muscle at the lower end of the esophagus is very tight and fails to relax. So all the treatments are geared towards making that muscle more lax. So for example, endoscopically, which is with the camera down through the mouth and into the food pipe to look at this area, you can treat the condition by giving Botox injections, or you can treat by stretching the muscle with a balloon. It's called dilatation. So to stretch it, to disrupt the muscle so it gets more lax. Now, those are very temporizing treatments. They don't give you a complete cure, and long-term prognosis after those treatments is not as good as the more definitive treatments. The more definitive treatments are really related to surgically cutting the muscle to divide that muscle at the lower end of the esophagus. And traditionally, for over 100 years, what we were doing is we were doing surgery through the tummy. Initially, it was open surgery and cutting that muscle from the outside of the esophagus, the food pipe, and the stomach. That muscle is called the lower esophageal sphincter. We were cutting that with open surgery for 100 years. And then we moved to doing keyhole surgery to do the same thing from the outside with cuts through the tummy. And now, very recently, over the last decade and a half, what we're doing is natural orifice surgery. We're doing it through the mouth without any cuts in the tummy. And that's a procedure called peroral endoscopic myotomy, or POEM in short. And what that means really is that you can, through the endoscope, through the camera which is going through the mouth, we can actually divide the muscle without making any cuts in the tummy. And the advantage of that is that it's a day case procedure. It's not with any cuts. The recovery is much faster. And all the evidence suggests that it is just as good as the keyhole surgery to divide this. So in my practice, I tend to favor using POEM as treatment for achalasia. So with patients with achalasia, it is a very challenging time, and there are lots of very good forums that I would recommend online in terms of management of your condition with achalasia. The difficulty is that there is no cure of the problem, but certainly we can make symptoms better. If you look at the data for patients that have had surgery or POEM procedure, then what we can see is that there is up to a 93 to 95% success in terms of curing the patient's symptoms at 5 years and at 10 years. But obviously, there are a small group of patients that what we find cannot be cured of their symptoms, and they still have some residual symptoms and may require repeated treatments. So although we can't completely cure the condition, we can certainly make your symptoms much better. And therefore, we can provide you with an avenue to actually eat and drink easily and keep your weight stable. So I would certainly recommend that if you have symptoms that account to achalasia, that you seek medical advice so that you can be investigated and see whether you're suitable for one of the more minimally invasive treatments.